Madinah Institute for Leadership and Entrepreneurship, MILE.
Thank you for such a wonderful introduction, and I very much am looking forward to being able to join you in person in November for the HPHO. That really looks like a wonderful event, and I'm delighted to be invited to be a part of that. You'd asked me today to speak a little bit about some of the work that we've been doing in how healthcare delivery can be rethought using ideas from other sectors that have been very successful and that are starting to see some wonderful success in the healthcare domain, and that's using business model innovation. And so what I was hoping to do today is to spend a bit of time talking about some of the challenges that I'm really seeing as being critically important and that offer an opportunity for us to improve in healthcare delivery space. So I'd like to first lay out what are some of the challenges that I'm seeing in countries around the world, both here in Europe where I'm working a lot, in Singapore and Southeast Asia where I work a fair bit, but also in the GCC countries, which I've had the pleasure to get to know a bit over the last number of years. Once we look at some of these challenges, which seem to be common across these geographies, I'd like to look at what is the role of innovation in potentially giving at least a way to solve some of the problems that we're seeing. And I think there's a lot of promise there. At the same time, I think that there's also a dimension of innovation which is actually causing some of the problems. And so I'd like to take a look at that a little bit and try to pick apart, well, what are the ways that innovation is helping and potentially could help more? What I'll argue is that something called business model innovation could be something that is really worth looking much more closely at. I'd like to give some examples of business model innovation, both from other sectors beyond healthcare, but also from healthcare itself, and try to pick apart what is seeming to make them work better. And when I talk about business model innovation, just to clarify, the direction where I'm trying to go with this is that business model innovation is about thinking creatively, strategically, and in having a learning organization in a way that helps us to reorganize the types of resources we have, the way our processes are configured, in a way that shifts risks and information sets around in clever ways so that we can deliver care better. Well, that's an abstract notion, but I'll try to make that very tangible with some specific examples. So why don't we get started? Let's just jump right in. I think one of the things I'd like to do to start out is to just try to describe some of the challenges that are there, because I think the world is changing very quickly, and I think it's important to see where the world is going so that we can better address the needs of tomorrow in novel ways. One big trend that is changing the mental map, the landscape of healthcare, is certainly medical and technological innovation. Pharmaceutical sector is coming out with some wonderful new treatments, therapies. The equipment industry has got some wonderful technologies, devices, diagnostics, implants. These are doing some wonderful, wonderful things. But that's not all. There are a lot of other trends that are going on that really, I think, cause us to want to rethink our mental map, our way of viewing the world a little bit differently. Another is the role of information. When I was growing up, we didn't really have computers in every home. And now the number of homes that have computers is astonishing. In fact, many of us carry around cell phones in our pockets. Turns out that more people have access to portable phones than have access to toilets. And so that's an amazing thing when you look in developing and emerging areas of the world. That's a big change in terms of the availability of information. What that has meant is that people are generators of information and not just consumers of information. Apple recently came out with the iPhone 6. There's a new operating system there, and there's a health app, and it's allowing people to enter data and keep track of their health and wellness data in ways that just were unimaginable even a decade ago. Certainly that information allows us to look at a lot of variation in outcomes, in behaviors, and allows us to not look just at averages. And I think in a lot of situations we're used to looking at averages. We have the possibility in many contexts to be able to look at a broader set of data, certainly much more than before. I think another trend that is influencing healthcare is demographics. The average lifespan of people today has increased dramatically over where it was 100 years ago. Infectious diseases have largely been controlled in many parts of the world in ways that were not imaginable not that long ago. And now there's much more focus on the mix of chronic diseases. Diabetes being one of them, a variety of other allergies, a number of other chronic diseases coming into play. There are also huge bubbles in the age pyramid. So different age groups being overrepresented relative to long-run averages or underrepresented in the age pyramid. People are living longer, and in fact, in some areas of the world, people are having fewer children. Other areas of the world, people are having more children. A lot of variation there. People are moving. Families are dispersed. In a lot of European countries, there's a dispersion of families, which means that children are not there in the same way as they were a few decades ago to take care of elderly parents, for example. And so the informal care system has changed. That means the formal care system is going to need to change as well. People have rising incomes around the world, and people's expectations from the healthcare sector are increasing through time, not only around medical outcomes, but around emotional outcomes. These demographics have also led to a number of economical issues in supply and demand. In many countries, healthcare budgets are being stretched. Healthcare providers are getting old and want to retire as well. And so there's an increased demand associated with more care for the elderly, more chronic diseases, and fewer caregivers. There are huge training delays to be able to respond. We can't just train additional doctors and nurse educators immediately. There's some time that it takes to train care providers. We're also seeing huge multinational flows of patients and providers. These are huge effects on where we get care and who's getting care. Alongside of the technology and medical specialization, we're having increased clinical specialization. We have subspecialties in hospitals being proliferated like never before. If we look at, for example, the coding system, the ICD-9, the ICD-10, we're trying to look at reimbursement. Many countries use this to try to decide who gets paid for what. There's a huge level of specialization, and often you hear patients speaking of the issue of, I feel lost. I've got my specialist, but what I'm doing with this specialist, the other specialist doesn't know about. So there's a coordination of care issue that arises from this. And it's not just healthcare specialization. Ministries of finance who are paying for care, education, health, environment, often are separated and don't always come together. It was wonderful to see a few years back in Oman at the Oman 2050 conference, bringing together of health, education, environment all together under one meeting to try to coordinate, to try to look at healthcare as a systemic issue. That children are raised and have parks and can play and lead healthier lifestyles. But this increased specialization is something we have to consider. A number of countries are worried about the efficiency of care. And efficiency of care can be linked to both cost in many cases. Healthcare budgets are being pressured in many countries. And can we be more accountable and more responsible for the resources? So can we be more cost efficient is one issue, and often lean management or Toyota production systems are raised as potential ways of approaching that. Another dimension of that is maybe we can reduce wait lists. And so a lot of countries are focusing on this. health is moving. We see wonderful examples of healthcare and hospitals employing these techniques. But is that enough? Is that enough to ensure that we have consistent outcomes and consistent effective collaboration? These are wonderful questions that we can look at. And the list goes on, right? There are a lot of other reasons why healthcare, I think, is in crisis in many ways around the world. As people mix, as countries mix, working in Abu Dhabi, the number of different countries which are represented amongst the clinical staff is amazing. And amongst the patient population is amazing. So how do we manage all of those differences? The world has changed. Our mental map that we've been used to, or that many people are used to thinking about, just doesn't hold anymore. The world has been changing. How can we deal with that? Right? And does it matter? Well, I know that diabetes is a big concern in the Gulf states, and that's something I've been looking at a bit in my research and working with clinicians and insurers. You know better than me the challenge in the GCC states in Saudi Arabia and in many countries in Europe as well. I've got some data from Dr. Ali bin Shakar, who was the Director General of the UAE Ministry of Health a few years ago. He was sharing with me the challenge of diabetes progression and the associated costs with renal failure, with diabetic retinopathy. The cost crisis associated with the increase in prevalence and the projection here to almost 1 million people in 2025 is putting extremely heavy pressure on the finances of healthcare delivery. In fact, this slide was given to me a couple of years ago by Dr. Ali bin Shakar, and it turns out that even more recently, these projections are going to be, they're underestimates. The situation is worse in the UAE than he was projecting, and that's the case in many, many countries. So I think there is a crisis. Now the question is, well, what can we do about that? Well, as we mentioned, one way to go about that would be to try to focus on being more efficient, just doing more things faster and with less expense, trying to do it with high standard quality. Now, that's an approach. And I think that there's a huge role for doing that. This does help. And I think a lot of people are wondering, is it enough? Some countries are having to resort to rationing, meaning maybe I only provide care for certain procedures and I'm not going to provide care for other procedures, or I have a limit as to how much I can do, and that will create waiting lists. Certainly our colleagues in the United Kingdom are really concerned about the waiting list and how that might play out. Another approach, and I'm not advocating this approach, but another approach is, well, maybe we should lower our expectations. Maybe we should not expect so much out of the healthcare system. And while some people might suggest this, I am more optimistic. I think we can do more. I think we can meet some higher expectations, and I think one way to do that would be to try to do things differently. Now, this message is not a new message. In fact, a little over a decade ago, the Institute of Medicine wrote a number of reports, one of them being the Institute of Medicine's Quality Report, which really says we don't have a slight gap between what we need to do and what the demand is. We have a huge chasm. The current care systems can't do the job, they wrote. Trying harder is not going to work, so the efficiency argument is not going to be sufficient. We need to change the care system. We need to make the right thing to do the easy thing to do. And so that means let's try to recreate how we're doing things within our existing structures. Another idea is to say, let's change that system completely. And so this is where the innovation comes in. This is a very exciting thing. And, and just speaking with different people working in different parts of the healthcare system, research, healthcare delivery, payers, there's just so much excitement amongst everybody to look at innovation. And I've got a huge list of different ways that people are innovating. Devices, diagnostics, we've talked about some of these. Also gene therapy, telemedicine, mobile health, robotics and other technologies that might de-skill. If you look at the list of medical trials that are out, it's just amazing. It's amazing. In fact, you could almost drown in innovation. It's like it's impossible to keep up with all of the literature. It is very easy to feel overwhelmed and underwater with just this flood of information that's coming at us. I'd like to think about, what is that innovation really all about? And just ask ourselves, well, what are the greatest innovations, and can we learn something from that? Well, one set of innovations, you know, if I ask people in a group of people, they'll often say, well, iPhone, that's a wonderful innovation, or cell phone, that's phenomenal. Or if we talk about health, MRI, oh, look at this great imaging. We can do some fantastic things and learn about what's going on inside of the body. These are amazing innovations. Routers for information systems, the computer networks that we depend on, and which are enabling this webinar, by the way, require these computer routers made by firms like Cisco who create technologies. Now, you know, we could look to health, more health, vaccines. The invention of the smallpox vaccine was an amazing innovation. Invention of clean water. Drinking water probably has saved more lives than any health intervention to be invented, potentially, over the last number of years, or antibiotics. These are phenomenal innovations in healthcare. So, you know, how does that innovation happen? Well, there's a standard theory of innovation which says that often innovation happens in one of two ways. One is somebody comes along and invents a product or a device or a vaccine or a treatment, and then says, well, let's find where's a market need that could be addressed by that. Okay? Another approach is more customer focused rather than technology focused, more market needs focused. Says, well, what are the big needs that are not being addressed? And then let's go shop around for a technology that might address that need. And the theory goes that if you can make a good match between the technology and the market need, that magically you've got a wonderful innovation. So that's one theory. That's very product-oriented, and I think that when we talk about, well, what is innovation, it's easy to think about technologies and to convince ourselves of a beautiful story that says it's all about matching technology and market needs. I'd like to argue that's not necessarily going to be the most successful mechanism for having a huge impact. I'm going to argue that innovating through new products and technologies like this is very, very hard to do. And on this slide, I'm illustrating a number of extremely good companies who have failed miserably with a number of innovations. The first example, the Apple Newton. Apple is often raised as one of the leading innovative companies. But the thing is, they had a lot of failures too, right? The Apple Newton didn't take off. It was a little bit too early. It was ahead of its time in terms of a personal assistant, and it received a lot of investment, $1.5 billion measured in 2010 US dollars, but it didn't work out. If we think about the Apple Macintosh, there was a competing product when that was first coming out. It was called the Lisa. And Steve Jobs thought that the Lisa was going to be the big hit. But it turned out that the other thing was the big hit. The Macintosh was the big hit. And it's not just a story about, you know, if I have great technical quality that I'm going to succeed in the marketplace. Sony came out with a video cassette recorder which had a 60-minute playback. It was called the Betamax. But nobody wanted to buy it because you couldn't play a whole movie because the high quality meant the duration of the recording would be shorter. So the lower quality image with the longer cassette, the VHS, was the winner. It was not the first entrant. It wasn't the higher technical quality, but it won. And there are a lot of other examples of organizations that really understand marketing needs that have lost a lot of money on bringing the new product to market. It's very hard to predict whether a product will succeed or fail in the marketplace unless you're very careful about learning what the market really needs. So those are some anecdotes, and the plural of anecdote is not information. Let's take a look a little bit more at a broader set of information. Right? So here are some other examples which provide data that says that putting money into R&D for product innovation is not necessarily going to lead to success. In this particular graph, on the x-axis, on the horizontal axis, I'm displaying what is the amount of R&D spending relative to revenues over a 5-year period. So Sun Microsystems was spending, for example, about 10% of its revenues on research and development. And Dell was spending about 1 or 2%. Then I looked at, well, what is the average growth rate of these firms in the computer sector for the following 5 years? So that's an interesting story. Usually when you invest in R&D today, you expect a return in the future. What is the clear trend you see in this graph that links R&D spending on products to the growth rate of a firm? You see a clear trend? Well, in fact, it's a trick question almost, because there is no clear trend. There's not a strong association statistically between spending money on R&D and products and growth rate of firms in this particular study. Predicting whether that R&D spending will lead to success is hard. Right? A certain minimal spending is required, depending on the model, but it's not just throwing money at problems is not a solution. Now that's a computer industry example. Let's look at a health example, because that's what we're here for. And the story holds true here as well. The light blue bars give the life expectancy of 20 or 30 different countries, and I've arranged it so that this data from the OECD is listing countries from long life on the left part of the screen to shorter life on the right part of the screen. Then in the line, the thin line that's jumping up and down, I'm plotting the per capita spending. Now what you're seeing here is that there doesn't seem to be a clear trend between the per capita spending and the average life expectancy. Now if we put in developing countries, poorer countries in Africa, there would be a strong link between basic spending and life expectancy. But once you get beyond a certain level, throwing more money at the problem does not necessarily help improve life. So what I'd like to do now is now that we've argued that R&D spending and throwing money at product innovation is not necessarily going to help, I'd like to turn to business model innovation as an alternative. I think it's a great alternative because it says, let's rethink our resources, rethink our processes, not huge investments. Can we make a more predictable improvement than the bet of throwing money in R&D? Let's look at a couple of examples. Let's look at Dell, the computer company, for example. They did not invent the computer. They invented the notion, brought the notion called build to order to the personal computer industry. And so this is a very familiar story. On the top timeline, I'm displaying what is the original way of selling computers through storefronts. A company like Compaq or HP would try to figure out what are the components, figure out the assortment of components that go into the production plan. Then they produce. Then they sell in storefronts, and because they have to guess far in advance what type of computers will be sold, there's a certain risk associated with the forecasting. And so a lot of computers need to be discounted, and they get sold at 30% off, 40% off if they don't move quickly. The innovation of Dell, the innovation of Michael Dell was to say, let's set up an IT platform, try to find a set of clients, business clients that have very limited variability in the type of computer that they would want. We reduce the assortment and planning of components. We wait for the sale to happen, we assemble quickly with a limited set of choices, and then we produce after we've made the sale, and we ship. So it works, it essentially is eliminating this risk of forecasting. It's eliminating the risk of trying to guess far in advance what needs to be produced. It's switching the order of a couple of events and trying to respond very quickly to market demand. And the result is no overproduction or underproduction. What does that mean? Well, operationally, it meant a couple of big things. It meant, kind of in this top bullet here, what is it that the performance of Dell brings that the others did not have? Well, they were able to speed up the number of times inventory would circulate through their system from about 8 to about 50. So what does that mean? In that sector, inventory costs money. Inventory costs about 20% of its value per year to hold. If inventory gets sold 8 times a year, or cycles through 8 times a year, that means that the price of a computer at the competitors of Dell was about 2.5% of the price of the product. For Dell, that number is about 0.5%. 20% per year divided by 48 computers per year sold with that money is 0.4%. So you're saving 2% on inventory costs. The story gets better for Dell, right? If the cost of obsolescence is 25%, this is conservative, meaning if you hang on to a particular computer, you sell it for 25% less at the end of the year. Easily, 25% is minimal amount of discount. You're shifting from 3% of the cost of a computer being associated with discounting costs to 0.5%. You're saving another 2.5%. So the Dell model of doing things differently, of reducing that risk, is saving them 4 or 5% of their cost every year. If you could save 4 or 5% of your costs every year, I'm sure you'd be delighted to do it. If it just meant slipping a couple of events a little bit differently in terms of the order that they get done. Now, this idea of build to order really worked for Dell. It will not work for all industries. Right? There are some reasons why this worked in this computer sector. First, inventory is very expensive. Second, assembly is very fast. You can turn things around quickly once you get the order. Finally, the customers wanted some variety. They're willing to wait, but actually the amount of variety is not huge. Right? You can provide a fair bit of customization with a limited set of inventory. 3 different chips, 3 different hard drives. Just a limited set of options actually does most of the job. So there are a few reasons why this seems to work well here. Now, here's the thing about business innovation. Here's an important thing I'd like to raise. Business model innovation. Dell did not invent the computer. They did not invent a new market segment for computers. They didn't do the traditional theory. They just reorganized their processes a little bit differently. And that meant a huge shift in the risk. Now, if Dell were tried to, say, spend a lot of money inventing a new chip, their R&D people would not be able to jump over to a whole new industry, like fashion. I think we can agree that. Or we can't take a fashion designer and assume that they're going to build a new computer chip. The innovation process for products is sometimes very hard to map from one sector to another. Here's a critical thing about business model innovation. It's easier to map business model innovation from one sector to another. Here's an example of the Dell business model, shipping the order of sales and design and production to a very different sector. In that sector, I'd like to look at will be the fashion sector. Let's look at Zara. I'm sorry, I'm going to have to erase my drawings here. Zara is a chain of fashion that I'm sure many of you are familiar with, came out of Spain, and they essentially have used Dell's value chain idea in the fashion world. Totally different sector, creative fashion designers, what is it that Zara did that beats the traditional garment chains like Marks and Spencer? Well, Marks and Spencer had the traditional value chain. We go out and we have some designers decide what's going to sell next year. We go and procure the best materials on a low-cost basis. We outsource that from a low-cost country. We cut, we sew, and we ship, and we have a high-quality to price ratio. But you really have to forecast over quite a long time period. At least that was the traditional model that many large-scale garment sellers were using. Zara said, no, let's not do that. Let's watch to see what is trendy in a very specific segment of people, young, trendy people, and see, well, what are they wearing? Can we cut and produce quickly to deliver what we know is going to sell over the next few weeks? And they developed a supply chain that enabled them very quick, turned around products in just a month and put it on the shelves. And so they had eliminated much of the uncertainty about whether or not a particular product would sell or not. So what they've done is they've postponed the final design of the fashion until they knew what was likely to be fashionable. So it's using this kind of Dell idea of waiting to see what's going to sell and then produce quickly to meet that market need. These are examples. Zara and Dell would be examples in this sense of a customer-centric organization really looking to what's demanded. So that's an example as well of mapping from the computer sector into a fashion sector and seeing how that business model might impact that organization. Did this business model innovation make an impact? I think it's easy to answer yes to that one. Dell's organization grew like crazy, and he became a very, very wealthy man, and many people own Dell computers. It would be hard to argue that Zara was not a successful story as well. Amancio Ortega, who started the Zara and the Inditex chain, or family of companies of which Zara belongs, became the third richest person in the world. So that says that you don't have to invent a new technology, you don't have to invent a brand new market space. Just by focusing in on a particular area, solving the needs, shifting events around, you can create a huge amount of value. Certainly, Michael Dell and Amancio Ortega are examples of that, using a similar business model. So they changed the computer and fashion worlds. Now, is this just kind of an anecdote, or how can we think about this business model innovation more broadly? And I would argue that it is a very broad idea. There are business model innovations all over the place, and this is not necessarily a new thing. We often think about Amazon, so I'm looking at the bottom of the screen here. Amazon revolutionized the way the book selling industry works, and they're doing much more now. They're innovating in cloud computing and other spaces as well, but the original disruption was in this space of rethinking how bookstores should work. They did that by allowing an internet access to centralized warehouse, and then shipping out from that centralized warehouse, or shipping direct from the producers of books, and eliminating a middle person in that story. You didn't have to physically hold the book before you bought it anymore. Well, it turns out that that business model innovation is not new. Right next to that icon for Amazon.com, there's a Robux icon with a cowboy in it. It's about a 100-year-old photo. Sears and Roebuck is a very large retail chain in North America, and one of their big innovations was to invent the catalog. And so rather than forcing people to go into big, large commercial centers, to shopping malls, or rather than having traveling salespeople carry around a lot of products to rural areas to try to sell goods, so that people could hold them before they bought them, they shipped out this catalog. And so this idea of increasing sales by centralizing production and centralizing inventory and allowing people to buy remotely by looking at information, well, that was invented much earlier than Amazon, certainly at least as long ago as Sears and Roebuck. And a lot of other examples. Henry Ford didn't invent the car. His innovation was a business model innovation. He invented the assembly line. He used specialization and standardization, and that disruption cut the cost of producing a car from $3,000 to $800, a radical transformation. So my argument here is that business model innovation has been and is an extremely powerful force in many sectors. Second main point is that a lot of these ideas can be translated from one sector to another sector relatively easily. The question could be, does it also apply to healthcare? That's a critical question. My answer to that will be yes. And I think there's some beautiful examples out there, and I'd like to share with you a couple of those. One of those is a little bit older example called the Schuldeis Hernia Center. That's a specialized clinic in Canada that does one thing and one thing only. It does simple inguinal hernias operations, and it's basically an assembly line concept applied to rapid, low-cost hernia operations, and it's been tremendously successful. I'd like to share with you a little bit more about another business model innovation, which is also this notion of focusing and trying to have extreme standardization, and that's lostery clinics. So let me make a few words about lostery clinics. Lostery is an organization based in Finland. They have a number of clinics in Finland and in Sweden, and I think they've got just a beautiful innovation. I've got some pictures here that shows their clinic. Basically, what they've done is they've taken this idea of retail medicine, which has been growing like crazy in the United States, and they've mapped that to Finland and Sweden, where the rules and regulations around healthcare provision are different, in particular with respect to nurse prescription and so forth. What they do is very interesting. They treat about 15 to 20 common acute primary care conditions, each of which has a clear treatment protocol. They then remove the doctor from the clinic. They put the doctor off-site. Finland has a wonderful history in telemedicine, and they're using that here. They have a nurse in the clinic. Here you can see in the upper right of the picture a nurse examining the ear of a particular patient. And then in the lower left you see the doctor remotely reading the image and then trying to make the diagnosis and do the prescription if the prescription is needed. Very quick, fast service, low overhead, very focused on these specific acute primary care conditions. They have higher quality than the Finnish public sector in the sense of documenting adherence to best practice. Convenience is amazing. They're focusing on helping parents with sick kids. They need to get to work. They're looking for an easy way to get their kids treated and get the shopping done and get the prescription from the pharmacy all in one shot, and to do so with very careful, gentle, empathic care from a highly specialized nurse. Because of their cost structure, because of their focus, they've been able to eliminate everything that's not needed to provide care for these simple conditions. The cost is less than half what it costs the Finnish public sector to provide that care. The Finnish public system costs on average an estimated 110 euros per visit. That's the cost to the taxpayer, as compared to Lostery's 45 euros, less than half the cost to the patient. So this is an amazing thing, right? So if you look at the common acute primary conditions that are covered, that constitutes about 3% of the Finnish national health budget. If you could cut that in half, you'd save about 1.5% of the national health budget if you could replicate this model everywhere. So I think that's a very interesting story. Now, of course, the story is more complicated. We'll wait to see if this has a huge impact of some of these other innovators, but certainly the business model innovation here is focusing on very specific conditions, focusing on convenience and thoughtfulness for these conditions which are easy to stick to clear protocols, and using that telemedicine concept so that the clinician, the doctor, can actually serve multiple clinics at once. really a new way of thinking about delivering primary care. Here's another business model example. Here's from another sector, and we'll see how that applies to healthcare. One of the innovations that has emerged with Internet is this idea that you can have a centralized repository of information and then share that very broadly. iTunes, music sharing services, Netflix is a movie retailer that allows people to stream movies on demand over the Internet. These are examples of high customization that allow people who might have not the standard desires to actually still get what they need. By long tail, we mean if you look at the distribution of who wants what, these are kind of the really rare events. These are far out, lowly demanded books or lowly demanded videos, but they're still able to provide it because of their business model. Can that be applied to healthcare delivery? My answer would be yes. I think we're starting to see some beautiful examples in healthcare delivery using this type of an innovation. The idea is to invert that long tail. Okay, and so instead of looking at the rare requests, let's look at the rare customers that are consuming huge amounts of resources. When we talk about the chronic care crisis, a lot of times people have multiple comorbidities, and if there's poor access to care, maybe we can rethink how the care gets delivered to prevent a lot of the complications that might come with multiple comorbidities. Can we get the high-cost customers to be treated in a different way? So that's this idea of looking at the long tail and trying to solve something. So let me just finish this one last example, and then we can open that up to some discussion. I think there's some exciting potential points to talk through here. An example I'd like to just raise here is Dr. Jeffrey Brenner in Camden, New Jersey, in the United States. He took together a bunch of data and he tried to find who are the heavy users of healthcare resources. And he said, rather than treating everybody as an average user of healthcare, let's find the people that are heavy users of accident and emergency to get their care. And can we deliver care differently? So the short summary of the story, which is a wonderful story, I encourage you to look for Camden Coalition, Jeffrey Brenner on the web. See if you can search for that. He took data and tried to find where are people living who are using emergency room for care much more than the average. And what he did is he found that clusters of people were found in certain areas. In the upper right you have a building where a lot of really high, heavy users of services were causing huge costs in the system. And he set up a special nursing station there to triage out the easy cases from the harder cases. And he was able to significantly reduce the emergency care costs in this particular city, saving over 50% in these high care cost users. So I think this is another beautiful example of rethinking how we're delivering care, not treating every patient as an average patient, but trying to find, are there segments of the population where if we treat a little bit differently or we rethink the care process a little bit differently, can we save a huge amount of money? And the answer is yes. The answer is yes. It's just doing things a little bit differently and with a little bit different information. So I hope you can get a sense for some of the passion that I have, and we've got a zillion more of these examples, and I'm sure that we'll be able to have much more time to go through these at the HPHO. The underlying theme of these things is our usual way of thinking about how we're delivering care or how we're creating a business model around healthcare delivery might not be quite right. We might be missing a lot of uncertainty. We might be missing a lot of our of the heterogeneity that goes into building a model of what we think sustainable healthcare could be. I think the middle bar on this graph is sharing the key thing. Right? There are a lot of assumptions we're making about average patient, average cost, average benefit of healthcare, and we can rethink by looking at the outliers, by looking at the risks and uncertainty, and rethinking the order of events which we treat things, or setting up special practice to deal with outliers. We can save a huge amount of money and deliver much better care to a lot of people. And so I think that's what healthcare delivery should be about. So I'm really optimistic about business model innovation in care delivery. I know that's a lot of material, but let me just step back a little bit here, and perhaps we could open that up to some questions.
Well,
by the way, we will certainly have more opportunity to explore this, as you mentioned, Ali Jaffrey, at HPIHO on November 3rd.
Yes, indeed. Thank you very much, Professor Steve Chicken, for a very interesting, intriguing presentation. And folks, as the professor is illustrating the screen, the enrollment is open for our upcoming flagship program on high-performance healthcare organizations to be commenced on November 1st in Madinah, Saudi Arabia. So please do visit hpho.mal.org. Professor will be coming to Madinah also. Yes, Professor, can you...
Okay, now I can hear you again. Yep, thank you.
Okay, so let me go to the question box. Already we have a caller raised. If you have any questions, folks, please raise your hand or put your questions in the question box. Let me go straight to the caller first. We have Brother Zain Al-Rumani. Can you hear us, brother? Hello, Brother Zain. You raised your hand, sir. Can you?
Yeah, I'm hearing.
Okay, sir, could you please ask the question as you raised your hand, and please introduce yourself?
I'm Zain Roman. I'm from Integrated Telecom.
Hi.
Hello?
Hello.
Hello?
Yes, Zain, we can hear you.
Yes.
Could you please ask the question, Zain?
Hello?
Yes, Zain, we can hear you. Could you please ask the question?
Hello?
Yes, hello.
Are you hearing me?
Yes, we are. We hear.
Okay, Zain,
Yeah.
we can hear you. Could you please ask the question?
Okay, I mean, there's something wrong.
Okay, maybe let me move to the question box. Apparently, Mr. Zain is having some volume issues. We have a question from Brother Uwais Ali. The question is business model innovation the same concept as business process reengineering?
Okay, that's a good question. And there are a lot of concepts that have kind of come and gone, and some are still continuing to have great impact. The business process reengineering, I think, in many implementations, different people will have different definitions. Many implementations had a strong sense of the lean management, which was really is often focused on looking at pathways and trying to reduce waste in between steps and pathways, or trying to find different ways to reorganize resources, for instance, pooling of resources, pooling demand across multiple bookstores, for example, when making a reordering, or looking at pooling demand across countries for vaccines, for example, as I know the Executive Council of the GCC states is doing for purchasing vaccines. So that's business process reengineering. This does have a sense of reengineering. I think a key differentiator here is that with business model innovation, we're trying to look at where are the big risks that are being taken in a supply chain. And it's not looking just at your own organization. It's looking at the whole sector. So, for example, somebody like a Zara might look at the clothes production, the sewing, the logistics, and the retail experience. That's looking after multiple different functions. In some supply chains, those are different organizations entirely. Zara has taken an integrated approach. They've rethought the whole supply chain. Right? The idea of Lastry, the primary care clinic, that's saying I don't want to take the risk of having all sorts of complicated cases. I'm going to communicate and work with the local GP community, general practitioner community, and let everybody know I'm only doing these very simple things, pediatric vaccinations, ear infections, a few simple things. And I'll organize my resources just for that. So it's often deciding what not to do. It's sometimes trying to bring in more risk. So as opposed to getting rid of risk. So for example, GE, as an aircraft engine seller and maintainer, they shifted their risk from their clients, who are the airplane owners, back to themselves, and they charged a premium for that. They've taken the operational risk, and they've said, we're only going to get paid if the plane is in the air. We're not going to charge you for fixing the plane or fixing the engine. We're going to charge you for keeping the plane in the air. And so the incentives were changed dramatically. And so this notion of rethinking risk in an entire supply chain, I think, is one thing about business model innovation that is different than some of the more often used business process reengineering approaches.
Okay.
Does that answer your question?
Well, the brother answered in the question box. So let me move to the next question, sir. There's another interesting question. In your view, what are the major forces that are affecting innovation in healthcare industry? Is it technology itself, funding, public policy, and/or accountability?
That's a beautiful question. It's a beautiful question. Yeah, there are a lot of exciting things going on. I think in technology innovation, there's some great things going on in terms of fundamental science. And I think fundamental science is very important for sustaining the long-term survivability. But there's also going to be this kind of translational research and development. And there, I think the technology push sometimes is greatly successful, but sometimes not so successful. And it's there that I think, if there's a new technology, I think really rethinking about it in terms of the whole business model is critical to making it work. If you see the number of apps, for example, for smartphones around diabetes and health and wellness, there are thousands of them. Now, just by pushing more technologies, it's not going to be making people healthier. There's going to be something beyond the technology that makes it so that people actually use it and benefit from it. Okay, so I think that's an important thing. I think we are seeing this notion of business model innovation in a lot of spaces. In the reaction to the bird flu scare a number of years ago, the H5N1, in reaction to the SARS scare, all sorts of things around how, who's going to take the risk of producing a lot of Tamiflu or producing a lot of influenza vaccines. And there were a lot of interesting public policy decisions, and should the Department of Health, should Health and Human Services pay for the risk that's being assumed by these private manufacturers of vaccines? And the answer is yes. I mean, that happened. So their risk was being shared, and it was a shift in behavior of the public sector and the private sector. Now, I'm not sure how to legislate that. Right? Legislation can create a more fertile ground for innovation, but legislation doesn't necessarily create the innovation itself. Right? And if you look across countries, there have been different approaches to health policy. Different people have different systems. People innovate in all of those systems, more or less. So I think innovation will happen no matter what. If policy can help that innovation to happen in a way that keeps patients safe, that's a good thing. But I think there are multiple ways to achieve that policy. I think there's a wonderful innovation spirit, and I think we discuss a lot of this innovation spirit, how to adapt this innovation spirit of Silicon Valley, for example, or other very innovative places into healthcare. We do that with some of the executive development programs we're doing in our campus in Abu Dhabi, the Innovators for Community Wellness. I'm happy to share more information about that if you'd like to learn about that. But we try to focus really on what can people do within the care system and how to interact with policy, how to interact with payers, how to interact with other stakeholders to help make that happen. That's where a lot of our work is going right now.
Okay, thank you very much. We have another one, interesting one. With consumer-focused innovations, ventures that experiment with new business models often face opposition from local hospitals, physicians, and other industry players for whom such innovation poses a competitive threat. How should one cope up with such a challenge?
How does innovation, innovation can threaten the existing system, that's for sure. That is definitely for sure. And that's an issue actually faced in the case of Lostery, which I mentioned. When they set up their first few storefronts, there was some concerns from the general practitioners in the public sector and regions in the surrounding region. Will patients get a proper continuity of care? What if you miss a diagnosis of something that's important? Because a patient goes to Lostery when they really need something that's not on that list of 18 conditions that are handled. So there was a strong pushback, and I think coming up with a great new device or a great new business model is never enough. You have to fit into that ecosystem, and so there's some tools to help do that. One of them is called a business model canvas. But another is just getting out and talking to people and helping to make sure that their concerns are handled. And nobody likes change, right? So the change management part of this is a very important dimension. So that's something that we could spend a whole nother hour talking about, the change management. Absolutely important. And it's something that's got to be working hand in hand with the innovation.
All right, thank you very much. We have another one, short one from Brother Hakeem on Tunde. The question is, don't you think that the appetite to innovate and save costs in healthcare industries could lead to a compromising the quality of healthcare? If it does, what is the way forward? Yeah,
so there are several beautiful dimensions raised by that question. I think that's one of the things that actually the Lostery case also demonstrates. The cost per care or per visit was less than half, but actually the quality was higher. And the patients appreciated it more because the alternative was being on a wait list for an ear infection for a week for your child who is really unhappy. And so in fact the quality went up and the cost went down. Okay, so that's one dimension. We're not talking about cutting costs in a way that also decreases quality. We're trying to find a way to do things differently that decreases costs or keeps the cost the same and improves the value, or that reaches more people with the same set of resources. These are the types of things we're trying to achieve. It doesn't have to be a win here, a lose there. A second thing I would mention is a beautiful thing about the Zara case. Actually, Zara's cost per production is higher than the usual retailers. And the price that they can charge the customer is actually lower than what the competitors would be able to command. So how do you make money by charging less money per garment and having a higher cost per garment? Seems insane. The margins are lower. Well, the benefit comes because they've eliminated the risk of doing the wrong thing. Everything they produce sells, comparatively speaking, as compared to the usual sector. So how would that apply to healthcare? Well, there's some work we're doing in London right now and looking at some commissioning. How do people purchase care services for the population of London? And how do you decide whether or not the care is doing well or not? And they're doing something really neat. It's something around, is the care creating value? They're changing the discussion from how much does the care cost to how much does the patient actually benefit in comparison with the cost. It used to be that, I think the old way of thinking is that you say, am I compliant with hand washing in the clinic? Am I compliant with making sure that the patient gets the pamphlet about the side effects of the medication and the treatment? Yes or no? And measuring these process indicators. Now, measuring those process indicators is great for bringing us from poor care to good care. But to get the way to great care, that means following up and making sure, is the way that I gave that information to the patient actually improving outcomes? Are they having fewer complications? And so in London, they're trying to bring this into the care purchasing process. It's something called outcomes-based healthcare that they're working on. And the idea is to not just focus on the cost optimization, but how do we make sure long-term we have patients with fewer complications and happier outcomes, and let's avoid some of these cost of complications in the long run. So that's an interesting question, an interesting trend. It's really rethinking value instead of cost.
Okay, we have 3 more questions. So we have 3 more questions. I'll quickly run over them to you. The first one from Brother Sheikh Mahmoud. The question is, as you mentioned in Zara business model regarding what is in demand, what could indicators for business model innovation for tertiary care hospital or consultant clinics?
That's a great question. So I might put that back for tertiary care clinics. These are often more advanced stages. So I think some of these opportunities that we're seeing very successful have been where primary care has not been succeeding in the way that that people would hope. We are seeing some kind of specialized facilities for kind of the tertiary. We're seeing some specialist surgical units, like we mentioned the hernia operations. We're seeing this with dental care. We're seeing with eye surgery. We're doing a neat study of a group in India right now called Shankara, which is doing some really neat things around eye surgery in terms of what they're doing. So I think that in terms of approaching that, I think, I'm not going to know what is the right model, but how to approach finding that model. I think one approach is to find, well, how did patients get into that place in the first place, right? If it's emergency care, it's sometimes hard to predict that, but maybe there's some underlying causes for those risk factors leading to that. So for example, speeding and traffic accidents. Well, trauma care is directly linked to that. So if we're looking in that space, well, what is it that we can do with people around traffic and the traffic accidents? So it's looking a little bit more broader. And it might involve rethinking, who the partners are and who pays, right? So this reimbursement issue becomes very important because that tells you whether you can continue operations or not. Some of these interesting business models involve rethinking the risk, like the GE airplane engine risk sharing. GE took the risk of keeping the planes in the air and only getting paid if the plane was in the air, and that helped motivate them to even further improve the technical quality of their engines, to make sure that there were no needs for extra maintenance in that part. So in doing that, they shifted how the revenue flows to the airlines versus to GE as a service provider, how that happens. So sometimes it can be associated with financial incentives as well. I can maybe jump back a page or two if I can get my computer to control that. Yeah. So one of the things that we do in the executive programs that we're doing, and we'll cover in the HPHO as well as the programs we do at INSEAD in Abu Dhabi, is to just really help people try to think through how are these different approaches, the idea of focus at Lostry, changing the order of events like Dell and Zara, the long tail like Amazon and Camden Coalition, rethinking how much front stage activity there is in the front office versus the back office. That's another interesting mechanism. That might actually apply in this tertiary care example in the sense that sometimes people are finding that group therapy for recovery often works better than individual recovery in this setting. So often that's been the case in, say, drug rehabilitation sector or in, say, mental health area. We're finding also that in terms of cardiac surgery recovery that this can be useful, or other operations. So this playing with how patients interact with each other in the recovery area is something that might be an opportunity to look to there. We didn't talk about user-generated content, and we have a few other of these kind of just general classes of how to rethink business models. User-generated content is another wonderful way to rethink care. We've done some studies of patient groups who are coming up with new clinical findings. The Patients Like Me example would be an example of trying to rethink how ALS is being treated. And so that's, I think, an exciting development. That's created by surveying how people are reacting to certain drugs. So how patients with diabetes are interacting and learning from each other. Can we create platforms where people with chronic conditions can help each other and support each other in new ways? Huge opportunities for business models in that space as well. And so one of the things that we like to do is to try to create an environment where people can work with others, professionals in that same area, and try to rethink through those models in a way that's adapted to the local environment, as it should be.
Okay.
Sorry for a long answer to a very wonderful
We have
question.
2 more questions. Would appreciate if you could
Sure.
Give some short answers to them as well so we can conclude.
Absolutely.
First one is from Brother Furqan. How should you modify your corporate strategy that has been traditional to adapt or convert to business model innovation?
It's a beautiful example, and a lot of organizations have a very difficult time in doing that. In fact, we mentioned the Zara, we mentioned the Dell. Business model innovation is very hard. It's easy to translate from one sector to another. It's very hard for the traditional provider to change quickly. There are some examples of organizations that have done that. GE certainly has been a big innovator. But that requires a good deal of thinking. A colleague of mine, Hal Gregerson, has a wonderful book called The Innovator's DNA, and I would really recommend it to you if you're looking for some support in making that transition. It's really, there are several key dimensions to that. One of those key dimensions of that is helping people to understand why change is needed. You'll never get people to change unless they understand why they should change. And so in an organization, that's a huge challenge. The second big challenge that Hal identifies in that process of helping an organization shift is getting the organization to realize what's going to happen if I move, and do I feel comfortable that I, as a participant in this, have the tools to actually start to move in that direction. So why, and then do I feel I have the tools to move, and do I trust that if I use those tools, I'm going to make the change? The third one is lack of follow-through. It's lack of persistence. And because you can try and you can say, oh, the first 2 experiments failed, and therefore we're going to stop. And that's the third big category of reasons why these transformations fail. So I'd really recommend my colleague Hal Gregerson's book in terms of helping that. That's called the Innovator's DNA. And he has another book called It Starts With One. Highly recommended.
Okay, sir, one last question.
Was there another question?
Yes, so one last question. So really pressed on time, but let me take this one if you don't mind. Knowledge management versus information management in the healthcare. Is there a difference? It's a short one.
Knowledge management versus information management. So this comes down to definitions of terms, I think. Information management is often associated with technology and information systems. And I think that knowledge management goes beyond that as well in the following way. I think a lot of knowledge in organizations is implicit and is tacit, and people just understand how things get done and what feels right. And that it's hard to put into a computer system. And so I think all of that kind of, how do you help people transfer and learn and improve that implicit knowledge, that takes us beyond the information management, right? So knowledge management has a broader set of things, including this implicit knowledge, which is absolutely critical in many, many organizations. I think increasingly more critical through time.
Yeah,
happy to revisit any of those questions or follow up on any further questions that you might want me to follow up on.
Well, I mean, that really brings us towards the end of the webinar. Any concluding remarks that you would like to give before we dismiss out?
Well, again, I really am grateful for the opportunity to spend some time with you. I've been able to get to know the UAE for the last 7 or 8 years quite well, and I've had an opportunity to meet many people from the region, including many from Saudi Arabia, and I'm very much looking forward to joining you in early November for the HPHO in person, and we'll have an opportunity to go in much more depth on all of these things. And I'd like to also let people know that we do have 6-day programs, a 6-day program around leadership and management, and another program around innovation, especially in community level, primary care, public health, wellness. 2 separate programs that we run out of our Abu Dhabi campus in close collaboration with our partner Johnson & Johnson, who sponsors the tuition for the program. And I think those are all wonderful opportunities to dive much more deeply into these subjects than we were able to do in this hour that we had together. So I hope you'll consider all 3 of these events, MHLP, ICW, and the HPHO.
Well, thank you very much, folks, thank you all of those who participated in this webinars for posting wonderful questions, and I would like to especially thank Professor Sheikh for your valuable time, and we really look forward to seeing you in Madinah in the month of November. With that note, I would like to conclude the session with an announcement that, folks, we are recording this webinar, which will be uploaded on my community. Equally, we'll be uploading the soft copy of the presentation illustrated in this webinar by Professor Sheikh. So please stay tuned to community.ma.org. Well, with that note, we are going to dismiss out. So thank you very much once again. You all have a good day.
Madinah Institute for Leadership and Entrepreneurship, MILE.